Cheers, everyone. Before I get started today, I would first like to acknowledge that this presentation is being held on the traditional lands of the Wabanaki people and take a moment to pay my respects to elders, both past and present. Good afternoon, everyone. My name is Steph Tucker, and I am a project coordinator with the Tobacco and Substance Use Prevention and Control Program housed within the Maine CDC. Thank you so much for taking some time to listen in on an overview of current best practice substance use prevention strategies and how these practices can be implemented in school health education. I'm so appreciative for the opportunity to connect with educators who we know are absolutely instrumental in the delivery of health education programs and services. So I'm personally just so incredibly grateful for your diligent and ongoing efforts. Alrighty. So this presentation has been developed in recognition that there is often conflicting information about general substance use prevention concepts, as well as a lack of centralized resources for supporting the development of a proven and effective skills-based substance use prevention curriculum for use in health education. Today, I will be giving context and background on an introduction of the strategic prevention framework for substance use prevention, a summary of current best practice primary prevention strategies. I'll identify commonly used strategies that are not effective and should be avoided. And finally, we'll talk a little bit about a directory of reviewed substance use prevention resources and lessons that are available for you all to use. So like many other public health fields, primary prevention science is a dynamic entity that is constantly assessing, adjusting, and growing. The Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, developed the Strategic Prevention Framework, which is a data-driven planning process that aims to ensure that substance use prevention programs can and do produce repeatable results. So if you can recall the scientific method from your own school days, this is developed with that process in mind. Preventionists research, create hypotheses, carry out work to address identified needs, and then go back and measure the impact of that work to determine if it should continue. And the components of the strategic prevention framework include overarching through lines of sustainability and cultural competence, assessment, which is associated with identifying local prevention needs based on data through activities like needs assessments and environmental scans, capacity involving mobilization of human, organizational, and financial resources to meet project goals, planning, which is the creation of a comprehensive data plan with goals, objectives, and strategies aimed at meeting the substance use prevention needs of a particular community. It also determines cost and resources for implementation. Implementation itself focused on carrying out various components of that prevention plan, as well as identifying and overcoming barriers as they arise. And evaluation. What's been done well? What areas of the project need improvement? This step measures the impact of programs, policies, and practices to understand effectiveness and any adjustments that need to be made. So some examples here might be use of logic models, data collection tools, and external evaluator partners. Many of you listening in may be familiar with the social ecological model in one context or another. It has 5 levels that represent a broad approach to thinking about health and how it's affected by interactions between and among the individual person, their community, and the physical, social, and political environments that exist. We're going to take a look at alcohol as an example. And the caveat here is that the points that I'm going to talk about are applicable to any mood or mind-altering substance. And that's in recognition of the fact that all substance use during those early and key periods of adolescent brain development increase the chances of continued and possibly more consistent use later on. So if I were to ask the question, whose responsibility is it to decide whether to drink alcohol or not? The answer is usually the individual, represented here by that individual person graphic. However, prevention science indicates that the strongest influence on whether an individual drinks or not is actually determined by the characteristics of use among members of that person's social network. So their relationships, family, friends, neighbors, coworkers, and others. And this social network generally exists within an organization. So for example, a school or a workplace. Therefore, if an individual is contemplating wanting to drink alcohol, but there's a strong public health presence, a social environment that doesn't support use, so there's no after shift drink, group happy hour, or talk of alcohol use at work, or there are very clear legal and social consequences for use, then that social network is less likely to drink alcohol overall. And of course, that school or workplace also exists within a community, or potentially several. And it would be important to examine the makeup of that community. So, for example, are there lots of places to buy alcohol? Are these places grouped close together or close to schools or social hubs? Do existing signs and ads for alcohol make it look enticing, especially for young people? Is alcohol use something that is overall normalized in this community? For example, do we see people drinking at events tied to our social networks? And then that last and largest level represents the public policies and built environments that might influence alcohol use behavior. So some of those deterrents might include the availability of alcohol-free events, strong enforcement on the existing policies such as checking ID or limits on outlet density, which is putting restrictions on how many stores that sell alcohol can exist within a given community. And when determining how to prevent initiation or reduce substance use, primary prevention considers all of the social ecological levels or layers around a person and their impact on both individual and group behavior. As a super quick refresher, the social drivers of health are defined as the conditions where people are born, live, learn, work, play, worship, and age. There are those non-medical factors that influence health outcomes and often contribute to overall health inequities between individuals and groups. So some of the most common social drivers to think about in the context of substance use include income level, education, employment and job security. Some of those conditions that affect work-life balance, like access to quality childcare or after-school programs, food insecurity, access to safe and stable housing, a living space that's safe and comfortable, social protections, inclusion, and non-discrimination, access to affordable and adequate healthcare overall, reliable transportation, among others. So having access or not having access to these things directly impact an individual's overall health and well-being, which also extends to a person's risk for using substances and potentially developing a substance use disorder. And as educators, you undoubtedly already connect with students whose lives are impacted by some of these social drivers. So you're already seeing firsthand the way that these factors can influence every aspect of a child's life experience. And again, so much of public health and health education work intersects and overlaps, regardless of the issue at hand. So some of the most obvious connections that exist between primary prevention work and the efforts of the wider public health field is that intersection of social drivers of health, those risk and protective factors, and adverse childhood experiences. And in general, when the needs of all individuals in a community are met, those individuals are more likely to make healthy choices and can better handle life's challenges. Additionally, meeting those needs means their risk for developing a substance use disorder, suicidal ideation, experiencing chronic illness, and potentially even their risk of getting certain types of cancers can also be reduced. So where are these connections made, and who's involved in creating and implementing a successful substance use prevention program? One partner that can be particularly helpful to educators in preventing substance use is the community coalition, which is typically made up of formal, long-term collaborations between diverse organizations and constituencies who all agree to work together to achieve a common goal. These coalitions might include folks from various sectors, including but not limited to service organizations, youth groups and clubs, parents and caregivers, schools, teachers and coaches, healthcare providers, employer partners, religious organizations, state, local, and tribal governments, law enforcement and emergency medical services, media partners, and others. So some of you listening in might be connected and interacting with community coalitions already, or you might be a key figure in those coalitions yourselves. So folks who hold various roles along this care continuum work together to collectively address the health and safety implications posed by alcohol and substance use, while simultaneously working on large-scale and intersecting systems issues. Among educators, community coalitions can definitely serve as a great resource for supporting substance use prevention through consultation or coordinating a partnered approach to delivering those best practice and age-appropriate prevention lessons. One of the connections we mentioned on the previous slide was adverse childhood experiences, or ACEs. And while there's an endless list of events in childhood that could potentially cause trauma, ACEs refer to a specific list of particular adverse conditions that, when they happen before an 18th birthday, are linked to a higher likelihood of harmful health behavior later in life, such as struggles with mental health, overeating, or substance use. ACEs have the ability to echo across generations as well and create cycles of harmful behavior within families or within all relationships. Again, thinking back to that explanation of the social ecological model. And naturally, this doesn't mean that someone is guaranteed to misuse a substance if they've experienced one or more ACEs. The truth is that there's many other factors within the social ecological model that can impact a person and provide what's known as PACEs, or positive childhood experiences, and those foster resilience in an individual. So here, it's important that we explore PACEs with you a bit further. We tend to hear a lot about the negative consequences tied to experiencing ACEs, but it's not always a helpful measure to use, especially when working with children directly. There's stigma that's tied to these experiences, and it can make it really difficult for a child or even the safe adults in their life to feel hopeful about that child's future. That's one reason why building up positive childhood experiences like familial support, positive peer relationships, and fostering a sense of school and community belonging can serve to counteract the effects of adverse childhood experiences and support resiliency and other protective factors that are so important to those positive health outcomes. And I want to take a few minutes here to really clarify the role of prevention. There's three overarching domains of prevention science. Those are epidemiology, so what is the problem? Intervention, how do we fix the problem? And research methodology, what works, how does it work, and why does it work? Primary prevention aims to prevent substance use before it starts, or at minimum, delay the age at which a person first uses substances. And this usually means focusing the work on children, adolescents, and young adults, along with educating families and communities. It's a science that tends to be nuanced, complex, and it's often misunderstood by other sectors of the public health field. However, when it's done effectively and with the help of certified prevention specialists, it results in long-lasting positive and population-level changes. These images are a few examples of primary prevention strategies that are known to be effective. Things like relationship building, encouraging quality connections, multi-sector partnerships, collecting measurable data, identifying evidence-based strategies and programs, and fostering environments for sustainable behavior and policy changes. Specifically, we'll be taking a look at evidence-based strategies and programs today and what makes a program work, since that piece is especially applicable to the role that health educators can take. We recognize that in the past, when looking at problems facing young folks and communities, public health professionals often went straight to finding those solutions and selecting interventions, meaning that they bypassed those first kind of petals in the strategic prevention framework and jumped straight into implementation. And we recognize that folks of the past did that with the best of intentions, but without a strong evidence base, those interventions of the past often threw programs at problems. And in hindsight, this didn't always end up being helpful for achieving the intended outcomes. So, to set the record straight, prevention is about using those evidence-based practices and strong community partnerships to permanently change behaviors, policies, and expectations in communities. Prevention is not following the lead on the war on drugs anymore. It's not dramatics or one-and-done presentations meant to weaponize fear, and it's not about overloading youth and adults with every overwhelming detail about a drug and the trauma that it can cause. Those approaches aren't based in prevention science, and they just don't create the change we want for healthier communities, so we don't practice those as professionals in the field anymore. For most of us, primary prevention really requires new ways of thinking about reducing our risk. So when we say reducing risk, we mean reducing the likelihood that a problem is going to occur. And unfortunately, we all know that good intentions and determination alone are not always enough. The cool thing is that all of us already practice prevention in a number of ways, and most likely on a daily basis. So things like brushing your teeth, exercising, staying hydrated, being financially responsible, charging our phones, wearing sunscreen, eating healthy. Those are all examples of primary prevention. And if we don't do these things, we might have natural consequences like bad breath. We might get injured or dehydrated. We might face financial trouble. We could get caught in the woods with no cell phone battery. We could potentially even lose our house. Some examples of those unintended consequences might be missing work, missing out on social time, experiencing long-term health consequences. And so these effects can compound and cause more problems. To protect the things that are important to us, we've all naturally learned how to reduce risk. We try to get a good night's sleep, and we get those regular oil changes. Again, these are all examples of primary prevention. We're collectively reducing risk, and we can readily understand why it's important to do these things, so they've become part of our routines. Well, we can translate and apply that same risk reduction in alcohol and substance use choices. Let's take a look at the role of protective factors in the context of substance use prevention. This is a very short list of examples, and I would really encourage you to look at some of the larger directories out there that exist. And the reason I say that is because when you're looking at evidence-based strategies that fit into anyone's life or work, looking at ways to increase these protective factors at each level of the social ecological model is one of the most attainable and positive ways to do that. We tell everyone who will listen that every job and every person has a chance to foster protective factors in prevention. Often protective factors cross over and are shown to actually improve a whole list of healthy outcomes for an individual, not just for substance use prevention, but suicidality, cancer prevention, health and fitness, and just overall quality of life. So when looking at this list, even here, we can see that setting an example with our own commitment to not using or misusing substances, involvement in our communities, and even just taking time to communicate clearly with the young people in our lives can impact our health and the health of those around us. Taking time to listen meaningfully is a protective factor. Honoring someone's pronouns is a protective factor. We don't have to bring out a whole parade in order to be a part of a school or community that scientifically sets folks up to manage their emotions, feel like they matter within their community, and measurably reduce long-term risk for substance use and addiction. And in the same way that we think about those protective factors, anyone has the power to look for risk factors that can be reduced or contained to create evidence-based change. This is especially true in schools because you've all already worked so hard to develop those natural relationships with students and are often some of the first adults to notice when a student is struggling with a range of challenges. Some of the things that you can do is become and stay informed about what laws and policies, or lack thereof, are proven to increase substance use or mental health, violence, and other issues affecting the adolescents around you. You can then advocate for the policies that line up with the type of school and community environment that you want to see for your students, your school, your family, and in your professional and personal spaces. All right. I know I've just provided a bigger picture overview of prevention science and what primary prevention for substance use can look like. But I also want to take some time to examine what does and doesn't work in the context of prevention. I think it's very clear that educators are invested in providing support, resources, and programs that are effective in preventing youth substance use. And our team at the CDC wants to help set you up for success in that. So what works? One evidence-based strategy is enhancing youth skills and their connection and sense of belonging in their peer group, school, and community. A lot of the strategies listed here are things that you as health educators and members of your school are already doing and doing really well. But I just want to reiterate how important these strategies are, particularly since they're often overlooked as tangible interventions. Things like focusing on social and emotional resiliency, providing interactive and engaging discussion, teaching and modeling age and developmentally appropriate refusal skills, and just being a caring and safe adult to the young people that you see and work with every day are all super effective and meaningful methods to carrying out best practice primary prevention. What we know doesn't work. Images and messages that are intended to shock or provoke fear tend to grab attention. An example that comes to mind is that old public service announcement of an egg sizzling in a frying pan with that slogan, "This is your brain on drugs." Images like that tend to be remembered and really stick with kids, but the research shows that they don't result in long-term behavior change and can actually backfire in instances where those images are disproven. So where a young person maybe experiments with a substance and doesn't experience that shocking image or consequences displayed. What else works? Let's look at multi-session intervention and integration. This is a huge one for health educators and is an area where you're likely to have the most capacity to influence positive outcomes. So strategies like implementing evidence-based substance use health education programming, collaborating with community partners, which I'll touch on shortly, and ensuring that your overall school is on board and fostering a positive, safe, and inclusive school climate for everyone are all key to creating the safe spaces needed to identify students at high risk and to intervene before those risks manifest in use or other long-term consequences. What doesn't work? Here are some of the unintended consequences of approaches that are in circulation now. These can sometimes be tough to wrap our minds around, but things like incorporating myths versus fact into lessons, showing images of substances or people engaging in substance use, and making sweeping statements about links between substance use and mental health challenges or suicidality is an effective prevention. Students tend to remember the myth about a substance behavior more readily than the fact meant to bust it, which can result in an integration of misinformation. Showing images of substances or folks using substances was a classic tactic of the DARE program, but actually ended up showing students how to identify which substances might produce a desired effect, or even taught students how to use them. And while there are links between substance use and suicide, making broad statements about substance use as the reason for an individual's suicide fails to take into account the many nuanced factors that may lead somebody to take their life. The reason that somebody may end their life can be incredibly complex, and sending the message that suicide has a specific cause or inevitability can actually increase suicide risk for individuals who may already be struggling. And we collectively want to set the stage to encourage resiliency and not create scaffolding for those negative self-assumptions or associations that take away any sense of agency. Back to looking at what works, let's talk a little bit about changing social norms. These are messages that emphasize the benefit of not using substances to help create positive social norms that reduce risk over time. So, for example, I'm choosing not to drink or use drugs in high school because I care about my performance on the basketball court, I care about my grades, I care about the respect of adults who are important to me, or the admiration of my younger siblings. Many young people incorrectly believe that most of their peers use substances, but the reality is that most young people don't use. Exaggerating those numbers to show kids how at risk they are doesn't produce the primary prevention results we want, which is to delay that age of first use of alcohol or substances as long as possible. Social norms are also made by the example we set. Anytime that a parent, teacher, or other trusted adult decides to manage their stress in healthy ways, instead of saying something like, "Oh, I need a cigarette or a vape or a drink," or anytime that an event is made chem-free to be as inclusive as possible, or in any situation where a choice is made around a substance, that choice is also perceived by others and could be part of that culture within the relationship layer of that social ecological model. What else doesn't work? One-time assemblies and testimonials. This is another really hard one to get away from. School-wide presentations or speakers who share their personal stories can be powerful and moving. However, research shows that these kinds of one-time events don't actually impact youth behavior around substances. Many of these assemblies focus heavily on dramatic, negative, potentially life-ruining consequences, and those tend to promote stigma and ultimately unintentionally reduce a student's likelihood to seek help if they are struggling. These are a few concrete examples of what current prevention science indicates is and is not best practice primary prevention. And as we mentioned earlier, this field has come a long way in understanding and applying strategies and interventions that are empirically shown to produce positive outcomes over time. And since primary prevention is focused on long-term outcomes, it's an area of study and practice that's always evolving and really takes collaboration with prevention partners and some intentional time to fully understand and integrate into solid practice. I'm not going to dive too deeply into the community factors that influence youth substance use, but I did just want to highlight that there are 7 primary domains that influence substance use behavior, and those include retail access, social access, community norms, family norms, enforcement, perceptions of risk, and price and promotion. Okay, so given all of that information, what resources exist to support you? The Maine Prevention Network, also known as MPN, is the state-level prevention structure to fund and support local work that carries out the prevention strategies that I've talked about today. The structure is fairly new and officially launched in 2023, and MPN uses a collaborative strategy to address substance and tobacco use prevention, healthy eating and active living needs, youth engagement, as well as mass reach health communications. MPN is broken down by public health districts. This map illustrates 8 of the 9 districts. District number 9 is currently managed by Wabanaki Public Health and is not assigned to a single geographic area, but rather serves the entire state. So we'll share links to this presentation, as well as the link identified here that will take you to the Maine Prevention Network landing page and provides contact information for the organizations that serve each of your regions. All right, we're going to talk a little bit about a resource repository that the Maine CDC developed in partnership with the Maine Department of Education. It intends to support health educators in the provision of current, accurate, and evidence-based primary prevention education that aligns with the national consensus for school health education standards and with the Substance Abuse and Mental Health Services Administration's strategic prevention framework. We'll give you a brief introduction to the resources here today, and would also encourage you to download this as a free digital download in the Maine Prevention Store as well, which will be included in the links that we share with you. And again, it's important for you to take some time to really review this page before utilizing the repository in your own classrooms. The curriculums and lessons outlined in the following pages again reference the National Consensus on School Health Education Standards, to which the Maine Department of Education learning results for health education standards also align. Some of the curriculum programs listed are free, while others have one-time costs or recurring costs, and these are based on the information available at the time of publication and are expected to be updated periodically. Some of the information included here is intended to serve as background knowledge for educators and might not necessarily be appropriate for use with some grade levels or students. These materials only have a Health Education 1 or health concepts listed under that standard. And finally, a skills-based approach to school health education is a primary prevention strategy that provides instruction on relevant and practical health skills, merge skills with current knowledge, develops the skills needed to practice health-enhancing behaviors throughout life. And with that, let's take a little bit of a look at the resources. So the programs on these next few slides are intended to be relatively comprehensive in terms of covering concepts associated with primary prevention for substance use. It's important to note that these resources are not comprehensive. They're a sampling of some of the quality programs that health educators might choose from to teach about substance use in the classroom. And as you can see, the resource includes program title, source, intended grade levels, a brief overview, kind of an approximate implementation timeline, what those associated national health education learning standards are, any specific areas of skill building, and the estimated cost, if there is one, based on the research done at the time of publication. And then these pages include more individualized lessons based on specific substances or topic areas that might be useful in supplementing overall lesson planning around these topics. They all still include a linked resource, source, intended grade level, overview, and those associated national health education learning standards. So we broke them out by individual topic area. I'm just going to do a quick run through for you here, since you will have the opportunity to review that resource digital download as well. All right, folks, as I wrap up this overview, I wanted to make sure that I give special thanks to those CDC and DOE partners who've just been instrumental in helping make this presentation and repository possible. So I'm specifically calling out Ellen Blake, Sheila Nelson, Megan Scott, Tammy Diaz, Emily Poland, and Susan Berry in appreciation of their subject matter expertise and contributions to this resource. And this kind of wraps up my presentation today. I so appreciate you taking the time to listen in and really hope that you find the information helpful in your work. I want to thank you again as well for just all that you do in the interest of the health and well-being of Maine's young people. Um, I think that we can't stress enough how appreciative we are of all that you do. Thank you so much and have a wonderful afternoon.